So my talk is on full endoscopic spine surgeries, and one of the commonest doubts in most non-endoscopy surgeons is why endoscopy? Why not continue with tube and microscope? And there are multiple reasons for that. I think endoscopy is definitely good for, it is one of the most sophisticated and most evolved forms of minimal invasive spine surgeries. And the basic principle of any MIS surgery is to minimize soft tissue and bony resection, which endoscopy completely fulfills till date. And the incision and the soft tissue damage, it doesn't vary depending on the size of the person. It's the same, whether it's an obese person or a very thin person, the incision is always 8 millimeters. We don't have wound healing problems because of those expandable retractors which we use in tube surgeries. And this is not the only trump card of endoscopic spine surgery, the skin incision. There are more important things to be discussed. Endoscopy is really very minimally invasive. For example, if you see this disc of L5S1, the entire surgery has been done by making a small slit of 2.5 millimeters in the ligamentum flavum. And if you compare the post-operative MRI done immediately next day, you see hardly any muscle damage. Even the rent in the ligamentum flavum is not visible. But the real milestone of endoscopic spine surgeries is the presence of irrigation channel. This irrigation channel does wonders. It maintains a clear field of vision. It has a hemostatic effect, and it significantly reduces the chances of infection. So there are less complications. Now here is a comparative video of a cervical discectomy. On the left side we are doing it with a tube and a microscope. On the right side it's the endoscope. And if you see, there is hardly any bleeding and the tissues are so well defined. So as compared to microscope, which offers a magnification and illumination, a bifold effect, endoscopy allows a trifold benefit, additional clear field of vision to what is already there with a microscope. Secondly, microscope always offers a bird's eye view. The surgeon's eye is placed at a distance from actual pathology, whereas with an endoscope, the surgeon's eye is very close to the actual pathology, just a few millimeters away from the pathology, because it is located at the tip of the endoscope. And this is very useful, especially in deep-seated surgeries. For example, this is a case of a thoracic disc, hard disc. Normally for open surgery, we do thoracotomies for such cases, and what we have done here is you just take a small incision and you insert the cannula retropleural, and once the endoscope is placed inside, you can completely resect, burr out the entire calcified disc, and this is definitely possible. The patient doesn't need admission for a long time. It's just an 8 millimeter incision, no chest drain, and the patient is mobilized the same evening. Another important advantage of endoscopy is not only it minimizes the access related injury, it avoids fusion. This is a very important factor. It avoids fusion, and this is possible because it allows need based approach. There are different approaches in endoscopy which are mentioned, and all of this, the main purpose of this is to minimize bone resection and to prevent instability. Now here is a case of L23 recurrent disc herniation. The patient had a previous laminectomy few years back. It's a centrally located down migrated disc herniation. If you try to do this kind of case with a tube and a microscope, definitely you will go for a fusion. Now this is done with a transformal approach under local anesthesia, and the entire disc has been completely removed without the need of fusion, and we have a follow-up of almost 8 years for this patient. So when to do endoscopy? Endoscopy is not for everything. Please do not try to do every surgery, even scoliosis with endoscopy. It's not possible. There are certain indications, and the main indications are disc herniation, stenosis, infection, some tumors, and it is mainly effective for focal pathologies. It is not effective for extensive pathologies, and the main reason for that is the amount of duration which is needed for the surgery and the amount of effort on the part of the surgeon is simply too much as compared to the benefit which is obtained by these MIS surgeries. So this is an excellent slide by Roger Hartle, and this definitely summarizes what MIS surgeries are capable of. These are usually single or two level surgeries, either fusions or decompressions. So how to do endoscopy? There are two basic approaches, transfemoral and interlaminar approaches. Both of these, they are incomplete without each other. They go hand in hand. You cannot be only a transfemoral surgeon or only an interlaminar surgeon. And nearly 30% of the cases can be tackled with transfemoral, and almost 70% of the cases can be tackled with interlaminar approach. So these are the main indications of transfemoral approach: foraminal, extraforaminal herniations, upper lumbar herniations, and low migrated discs. Whereas interlaminar approach is mainly useful for the lower lumbar spine, high migrations, and those associated with stenosis. So this is the case of a transfemoral approach, low migrated paramedian disc at L4-5. Here you see that I am cutting the annulus to expose the hernia, and that's the hernia there. You just release the annulus a little bit so as to free the hernia so that it can be easily taken out. And this transfemoral approach, it can be done under local anesthesia, it can be done under spinal or general anesthesia also. There you see there is a well decompressed nerve root, that is the ventral epidural space which you see, and this is the herniation which is removed, and these are the post-operative MRIs, 8 mm incision. Another second approach, interlaminar approach, very large axillary L5S1 disc. This is how you do it. You take an incision 8 mm at the center of the interlaminar space, insert the dilator, confirm the position, then you insert the working channel on top of it, and that's the final docking of the working channel. And once you insert the endoscope, you remove a little bit of muscle to expose the ligamentum flavum. This is the cutting of the ligamentum flavum. You cut it layer by layer till you expose the interlaminar space, and then you start cutting it, expose the subepidural space, and then you start cutting it towards the lateral side till you reach the facet joint on the lateral side. You identify the lateral border of the nerve root. Now since this was an axillary disc herniation, we shifted to the midline, and that's the disc, that's the axilla. You take a cut on the outer surface, and there's the, just a minute, last slide, and multiple fragments can be removed, and you can see it's completely, the bleeding is hardly anything, and there's the very inflamed nerve root, and there's the dural sac, and the entire surgery again has been done through a 2.5 mm slit in the ligamentum flavum. So these are the post-operative MRIs. So the take-home messages are, it's a very sophisticated and highly evolved form of MIS surgery. It offers a trifold benefit. The possibilities of various target-specific approaches minimize access-related injury and avoids fusion. And it is an excellent procedure for difficult to access areas, especially in the thoracic spine and the cervical spine. Thank you.